آم، السلام عليكم. بسم الله الرحمن الرحيم، وصلى اللهم وسلم على رسول الله. اللهم اشرح لي صدري ويسر لي أمري. جزاك الله خير, Dr. Adnan, for those who attend my previous talk about non-invasive. I promise, usually I don't repeat the same. I keep myself up to date, and I'm trying my best to not keep it more than every presentation I add, so it get everybody excited. And every time I go more deep, I teach myself before I teach you guys. So it's opportunity to be with you guys tonight, and I hopefully it goes as smooth as I can. And at the end, please write down any questions as we go, and inshallah at the end we'll try my best to answer all you guys' questions. So tawakkalna Allah. So I have nothing to disclose. So the agenda is going to be, we'll talk about continuity of care, and then respiratory care strategy very quick. And then we're going to focus about definition and classification of non-invasive respiratory support. And then we're going to dig more on each one of these non-invasive modules, and we will talk about it in details, and then where we are in the evidence among each one. So I would like to keep this one as always at the beginning, because the purpose is here to teach you guys that we have a strong enough evidence that use non-invasive respiratory support. It's almost always as a first line of treatment. The more you keep the baby away from the mechanical ventilation, is always better outcome, unless baby really need it. So always do your best. Before, we used to intubate the baby and keep the baby 27, 28 weeker, 25, then 26, 25 weeker. And nowadays we are even give a chance as early as 23 and 22 weeker. 22, 23 still in the gray zone, but at least 24 and above, we try the best to keep baby on non-invasive as possible. So that's the general rules for whether late preterm, early preterm would like to keep the baby on CPAP. Still, there is, I will cover this area, high flow versus CPAP based on the gestational age. And then if the baby is escalating respiratory support, we escalate to the NIPPV, although nowadays is more evidence towards start baby on NIPPV. And we will cover, so always there is who's best in IPV or CPAP. We will cover this as well. And then if the baby is not responding, usually we escalate it to the intubate the baby, and then extubated. We always try, especially for microbremy, non-invasive in IPPV, or they call it NIPPV in some centers. If baby is big enough, you can extubate the baby to the CPAP. If the baby full term, then you can extubate it to the room air direct. So let's start with the non-invasive respiratory support. As I said, we have too many terminology. First, we need to figure out what's the definition of each one, and then where is the evidence, where we are. High flow nasal cannula versus low flow, CPAP, NIPPV, and then which is bi-level of the pressure, or in NIPPV, and then the last one is the DUBAP, used to call it CPAP. So there is no way to cover any kind of lung pathophysiology or lung pathology without go back a little bit on the lung development. And that's because if you understand what we are doing, it's make it easier. And for the fellows, these slides, it's very, very important for your board exam. So we have a lung development. We have 5 stages, easy to memorize it. Every physician can save a life. Every, which is embryonic phase, physician, which is the pseudoglandular phase, which is canalicular phase here. And then we have the saccular phases and alveolar phase. So if they ask you which one is the most crucial for lung development, it's always, remember, is the C letter is the canalicular phase, because at the canalicular phase where pneumocyst type 2 give a rise for pneumocyst type 1. And you guys, I'm sure you guys know this, pneumocyst type 2, it's the cuboidal epithelium, which is give the rise for the pneumocyst type 1, which is squamous epithelium, which is important for the gas exchange. And in addition, pneumocystis type 2 is important for the surfactant administration. So at this stage, particular disease is very crucial. So that's why is the most important crucial step is the canalicular phase, which is the most important for save a life, which at which stage we start saving a life, which is S, at the saccular phase. So just remember, C, canalicular phase is a crucial, S is the saccular phase, which is that means save a lives, which is start, sorry, this one is not 28, usually start, I corrected, I don't know why it's not saved. It's around 24 to 36 weeks, and here up to 24 weeks. Okay. Okay, non-invasive respiratory support, we can classify to the high flow nasal cannula. And then we have a CPAP, and then we have the bilevel, which is the NIPPV, CPAP, now change it to the DUPAP. And then we have the high flow or high frequency oscillatory ventilation, nasal. The definition between the each other depend on the understanding the classification. So let's a little bit talk about the differences between high flow nasal cannula versus CPAP in NIPPV. So one, a simple definition as you control the flow with high flow, you set the flow, but you don't know how much the pressure. With the CPAP, you set the pressure. And CPAP also there has sub-classified, we will cover it later on. But really the classification is not as simple as this. So because at the bedside, and that's not just theoretically, that the bedside, I can see a lot of the mistakes from the RTs and the physicians, they forgot to look at the background. When we said high flow nasal cannula, it has one limb system. It has only one limb system. What does it mean? It's only inspiratory to the nasal cannula, and there's no expiratory limb. There's no expiratory limb. So there has to be way for the baby to exhale. So that's a very important concept. You cannot use nasal cannula and you block the nose. So it has to be, to call it high flow nasal cannula, it has to be the nostrils of your interface. That's part, we call it interface. It has to cover less than 50% of the nostrils. So that's the high flow. Why? Because we need the baby to exhale the CO2. There's no expiratory limb. And then recently there's no blender, but nowadays we have a blender so you can control the source of oxygen, how much oxygen you wanted to control. So you can do room air all the way to the 100%, depending on the saturation status. Versus CPAP, NIPPV, DUPAP, or CPAP, it has dual limb. There's small exceptions on the DUPAP. DUPAP has either double limb or the single limb, but majority the concept, all of them, they have there's small exception. They have a inspiratory limb and the expiratory limb. So when we said that, you cannot leave it, the interface has to block at least 80% of the nostrils to generate pressure and to keep it closed loop cycle. Because you have it, the expiratory limb. So you are not concerned about blocking the nose. So it has to be minimum at least 80%. Hopefully this message is clear. So let's go back. So here you can see the nasal cannula. It covers only less than 50%. So you allow to exhale. Sorry, it's not a baby, but at least it's easy to clarify or to demonstrate. Okay, so it has to be small bore cannula to allow greater opening for the expiratory gas to get out. Okay. Non-invasive respiratory support, we have a two-part. Either you control the pressure, as we said, and that's the CPAP or CPAP. And we have a two-part of it, or two classification. Either you control constant flow, so you have a constant flow, you cannot control it. Example, bubble CPAP. Example, ventilation CPAP or NIPPV. So either conventional CPAP, NIPPV, the mechanical ventilation, you set CPAP straight, or you sit in mechanical ventilation. It's NIPPV, it's the same mechanical ventilation giving through the nose. Has high pressure, beep, and I time and then have a rate. Versus CPAP, constant. Variable flow, CPAP, you have two, either you can use the CPAP machine and you click I need CPAP. In the CPAP machine, on the CPAP or the DUPAP machine, you can set CPAP pressure straight, but it has variable flow system. So it's flow changing to deliver the pressure required. Hopefully it's clear. So you have a constant flow, like convention CPAP or bubble CPAP. Variable flow, you have the CPAP or DUPAP. Hopefully it's clear. Okay, so this is the announcement for I have next week, inshallah, on Thursday, we will start the neuro developmental course. If anyone interested, welcome to text me. Okay, let's start CPAP. CPAP, this kind, like this bubble CPAP, we'll talk about it. You can deliver at the ventilation or bubble or variable flow as we talk about it. The interface of the CPAP, you can deliver, we don't usually do that, but you can use the nasal mask or nasal bronch or through the RAM cannula. So that's the interface. Let's talk about bubble CPAP. All these companies, I'm not advocate, but all these companies can deliver bubble CPAP. Bubble CPAP, what's the bubble CPAP? What's the concept of bubble CPAP? Bubble CPAP is very easy, very cheap. It doesn't cost a lot of money. What you need, source of oxygen. You need a blender to control oxygen. So flow, 100%. You can control the flow, how much liter per minute. Comes to the blender, or opposite, from the wall, come to the blender, and then you control how much flow you want it to come out. Okay? And then it goes to pressure. How much sink inside here, the water. The more sink inside, the more pressure you will generate. So here, numbers 5, 6, 7, 8. The more you dig deeper, the higher pressure you will generate. And then it goes to the cylinder, heated water, and then go to the baby. So this one just pressure you control, but here the blender system. And then, the humidified water. And then go to the baby, and from the baby, expiratory limb, that's when sink in the water. We said about it, how much pressure you control it. What's the advantage of the bubble CPAP? It's inexpensive, it's easy. Multi-interface devices can be set on it, or you can use it, but have a disadvantage. Another advantage is it has an oscillatory. You can see the pressure, although it's the being in the middle, but you can see as a high frequency oscillatory pressure on the bubble CPAP. In bubble CPAP, you control two parameters. You control the flow and you control pressure. The general recommendation is you keep it the same. I start with beep of 5, flow 5, beep of 5, flow of 6, beep of 6. But if you have a baby who's look at the bubble is not bubbling very well or has some respiratory distress, either you go up on the, or you can leave the pressure, you can go up in flow, you will generate it more bubble, and that's maybe it help. Disadvantage of bubble CPAP, unfortunate, because simple, it doesn't have the monitor built in. So what I'm trying to say, if the baby, the interface disconnected from the baby, there is no way to know that disconnected unless baby start desats, or you are close enough from the baby, you can see it's the machine is not bubbling, or the sink, the expiratory limb is not bubbling inside the bottle or can of water that's digging it. So that's the very important connection. So it has to, from the time, the nurses has to be close to the baby so she can see the bubbling. Or you wait until baby start desat, which is not a good practice. If the baby get apnea, another issue. If baby get apnea, no way unless baby start desats, or the same principle, there's no bubbling. Okay, so that's the potential risk. So you need a good nurses to monitor the baby, to keep an eye on the baby, and smart physician like you guys, so can be constantly go to the bedside and look at your baby and make sure your baby healthy and continue to be good. Because there is increased potential of increased work of breath and excessive flow rate at you might need to increase the flow to create PEEP. As I said here, you can control the flow, so you can give 4. So the study is measured the bubble CPAP versus ventilation CPAP. And here on the y-axis, you have the mean airway pressure. In the x-axis, you have the flow. In the constant machine or conventional CPAP is constant. The blue, if you set 4, it's constant 4, rate and the pressure. But the bubble CPAP, you can control. The higher you go in the flow, you might higher get the pressure. The study published recently in preterm lamb, 133 days gestation, intubated and randomized to the bubble CPAP 8 to 12 liter versus constant from the ventilation CPAP. And they have a certain parameter they look for. Number 1, they look at the enhanced ventilation, like the pH of the baby. So you can see this one, the pH on the y-axis, the time on the x-axis, the dark dots represent the bubble CPAP versus the white dots is represented the constant pressure CPAP, which conventional CPAP. And you can see the pH is better on the bubble CPAP. Similar in the BaCO2. It's controlled and keep it in the lower side, better on the bubble CPAP. Bubble CPAP improve not only the pH and the BaCO2, also improve oxygenation and enhance the oxygen extraction, as you can see it in this graph. So bubble CPAP, they explain the reason bubble CPAP slightly might work better because of the oscillatory or variable pressure from the oscillation associated with water seal bubble CPAP. What about conventional vent CPAP? Conventional CPAP, that means just through the mechanical ventilation, advantage, everybody know how to use it, nurse comfortable to use it. It's very easy. Disadvantage, you're gonna use the ventilator instead of using for somebody who's really need it. And a lot of our baby, usually we keep them very long, especially premature baby, we keep them very long before we decided to switch it to the high flow nasal cannula. Let's talk about now variable flow CPAP. And here we are talking about variable flow CPAP, not DUBAP, the NIPPV, or DUBAP, sorry. So by level, we are talking about just CPAP. So here is the variable flow. The key of the variable flow, either CPAP alone or variable flow DUBAP, that by level CPAP, the key is the valve, the interface. In addition, the DUBAP Fabian machine, they provide a little bit more. We will cover that part of advantage in their machine. But the key really to make it variable, the interface. It's not simple interface. It has the fluidic valve. This fluidic valve, it's different. So when you place the nasal mask CPAP or nasal bronch, have a constant. So if any one of you guys use it, if you put it in the nose, really it's you feel like it's annoying, because inspiration, expiration, when you do expiration, you feel something coming inside your nose. So it's really, it takes time to adjust to use it. Versus if you use variable flow, during inspiration, direct flow toward the patient. But during expiration, the valve is open, the part of that is get away with the baby. So babies feel a little bit comfortable, but the sit pressure, so you're concerned that you lose the pressure? No, the sit pressure is maintained still during expiratory phase. And studies look at this, where they found that babies with the variable flow, they have the less likely, or they have a more comfortable, less embossed work of breath. So advantage of the variable flow CPAP sit is a free stand. You can move it from one baby to another. It's not, you don't need to use ventilation. Has internal monitor, so in case baby apneic, in case baby disconnected, it's gonna be alarming system. The battery built on it, and synchronicity. It's a help the baby can be breathe comfortable. Disadvantage, it's upfront cost. Let's see the evidence among constant CPAP flow, which is when we said constant, we are target mainly here on the most of the study when talk about constant, that means mainly on the conventional versus variable flow CPAP, there is limited. So there is no strong randomized controlled randomized controlled trials to start, okay? But what we have the use of the variable flow CPAP in the study done on 2021, published in Pediatrics. The use of the variable flow showed to decrease the work of breathing in about 13 to 29% when we compared with the constant CPAP. And another study, systemic review, meta-analysis, although they are not strong enough, they found constant flow CPAP inferior to the variable flow CPAP, to the non-synchronized NIPPV, to the nasal high frequency, to the synchronized NIPPV. So if you trend them, it's the nasal or the CPAP constant flow in the least one compared with the others. Here, randomized controlled trials, they try post-extubation bubble CPAP versus infant flow CPAP. They enrolled small sample, 140 preterm infant between 24 to 29 week gestation, 600 to 1500 grammars. They look at the failure extubation rate at 72 hours. This is the primary outcome. The secondary outcome, longer at 7 days, and others, the total duration of CPAP support, chronic lung disease, complication, and they enrolled in the 71 baby enrolled to the bubble group and 69 non-randomized to the infant flow device. And they conclude bubble flow or bubble CPAP is as effective as infant or variable flow CPAP in the post-extubation management of baby. However, for the others, the infant ventilated for less than or equal to 14 days, bubble CPAP is treated with significant higher rate of successful extubation. So overall, is similar. In early, slightly better bubble CPAP than the variable flow CPAP. The disadvantage of the CPAP, and that's the put a lot of weight on number one, the nurses, number two, the physicians, fellows, specialists. When they round in the baby on the daily basis, they have to examine the area of the pressure spots. So when you use the nasal mask, you might create the pressure sore on the baby, especially at the nasal bridge, and can have a skin peeling skin and then abrasion because of the pressure. Sometimes very long time can cause nasal deformity. In the nasal branch, there's high risk of the nasal septum perforation if you are not take care of the baby very well. So there is nasal trauma, air leak syndrome on the CPAP, risk of abdominal extension, we call CPAP belly, gastric insufflation. In addition, it needs a lot of training for the nurses to keep an eye on the complication that we are talking about. Another example of the CPAP pressure. In order to prevent it, you can use the barrier. Okay? Okay, we don't have time for this, but this is my picture with my family and when I was a chair in one of the Islamic school in Illinois, Rockford. Okay, so we talk about here, excuse me, I'm gonna add another slide just to talk about high flow nasal cannula, because now we cover the CPAP versus, or let me, sorry, I'm gonna adjust very quick. Open this one. Let's talk about high flow nasal cannula. Okay. Then we will come to the last part. High flow nasal cannula. So we talk about CPAP. We cover about the concept of the CPAP versus the CPAP or the CPAP variable flow CPAP. We will leave the NIPPV at the end. So let's talk about heated or high flow nasal cannula. We said the high flow nasal cannula, it has to be open system. Number two, what's the definition of high flow? High flow, and it should be heated, any flow above 2 liter or 2 liter, at least 2 liter and above, that's when we call it high flow nasal cannula. Below, that's the low flow nasal cannula. Although in some textbook, between 1 to 2 is considered as a gray zone. Below 1 liter is 100% low flow nasal cannula. With the Johnson, the last recommendation for the chronic lung disease, he specifically reported as a 2 liter. So 2 liter and above, it should be heated, humidified, high flow nasal cannula. And the heated, humidified nasal cannula, it has to be number one, blender with the oxygen flow. So tank of oxygen, come to the blender, and then you have a flow. You control it from 1 all the way to the whenever 8, usually in units. And then it has to be a humidified system to the 37, heated 37, humidified 100. And then it has to be open system. That's what we cover, no more 50% of the nostrils. So when we call it heated, humidified, high flow nasal cannula, that's the criteria. We cover this. The advantage of heated, humidified, high flow nasal cannula reduce the incidence of air leaks syndrome. So if you compared high flow nasal cannula compared with the CPAP, the high flow nasal cannula less likely to develop pneumothorax, less likely to cause nasal or mucosal injury or necrosis, nasal granuloma, nasal vestibular stenosis, nasal septum, because there is not too much pressure on the nose, improve the comfort. And if you ask the nurses, they love the high flow nasal cannula over CPAP. It's easier for them because easier nasal care, and it facilitates breastfeeding. The disadvantage of heated high flow nasal cannula, it's unmeasured CPAP, cannot determine the pressure. We don't forget, when you use the high flow nasal cannula, it's easy for kangaroo care. So just you can place baby, enhance the boundary or the bounding between the baby and the parents, and support growth and development. If you use the ram cannula, also you can deliver CPAP through it. Kangaroo, the others, you can do it, but sometimes you have to be careful. It might get off. So high flow nasal cannula study look at the use of the heated, humidified, high flow nasal cannula. They found, and that's published recently, it's significant decreased nasal trauma compared with what we saw in the CPAP. But they have a higher failure rate in the small, tiny babies. So since the high flow nasal cannula discovered early, introduced into 2002, over years, the amount of the provider that use high flow nasal cannula is increasing, as you can see it on the red graph, compared with the CPAP on the yellow graph, which is constant. The mechanical ventilation is drop significantly over years. So let's compare heated high flow nasal cannula compared with the CPAP. People, because the main concern with high flow nasal cannula is you don't know how much pressure you generate. So people look at intraesophageal pressure between heated high flow nasal cannula with various, although all these studies, the small pilot study, small sample size. So 6 liter versus 6 liter CPAP, and they measured the pressure. They didn't find any differences in any of these studies. So an observation study found no difference in esophageal pressure between high flow when they used a little bit on the higher pressure site or high flow site, 4, 6, 8 liter, compared with the CPAP. The prospective observational study using electrical impedance tomography found the high flow nasal cannula 2 to 6 was as effective as a CPAP in measured maintaining the beep and the ventilation distribution, and that's recently published 2019. The other people look not only on the pressure, beyond that, they look at the comfort care. Pain is very hard, it's more subjective. They look at the noise. Why is important the noise? Because in the NICU, although it's not a practice in a lot of centers, when we was in the United States, we have a noise alarm, so it can tell us the amount of noise introduced in each room. So we have to understand, we have to be careful about our tone, about our sounds when we talk, when we round, when we give education. So it's like the signal light. If you turn red, that means you're too loud. If it's yellow, that means, or orange, that means it's be careful. And then green, that means you're good. So American Academy Pediatric recommended environmental noise level should be no more than 45 decibel level, because anything above 90 increase the risk of the hearing loss on those tiny baby. When they look at the CPAP versus high flow, they found almost identical. There's no, both of them, they produce more than 45 decibel, and there's no really differences. So let's understand the concept of high flow nasal cannula. So we talk about CPAP, everybody knows CPAP is the main function of CPAP is the decreased functional residual capacity, because it's the distended the alveoli. When you distend it to alveoli, you prevent the atelectasis, you decrease surface tension, and then you prevent the atelectasis. So that's the concept of the CPAP. Everybody knows the whole idea. We would like to recruit as much alveoli as we can, because if you have the unstable alveoli, what's going to happen? Unstable might make the others, the normal ones get more distended, the unstable get completely collapsed. And that's the concept, hopefully in the mechanical ventilation one day we can explain. But in high flow nasal cannula, the strategic or the concept is based on three main factors. It's based on wash out of the anatomical CO2 at the anatomical dead space. So that one concept. Number two, dynamic, creating some positive pressure that we talk about it. And humidity in high flow, humidified high flow nasal cannula, improve warming and humidity in the respiratory gases. So it has a three main functions. So let's talk about wash anatomical dead space. So we know in the neonates, it has close to the 40 to 50% of inspiratory tidal volume, it's kept in the anatomical dead space. So 40 to 50% of inspired tidal volume is anatomical dead space. The more premature baby, it's have a higher dead space compared with the full-term baby. When you start inspiration, anatomical dead space is filled with the CO2. Okay, so the high flow nasal cannula, if you don't have it, there's high chance of accumulation of the CO2, and that's increase the work of breath and to compensate the poor lung oxygenation. When you use high flow nasal cannula, the fresh gas, it washes CO2, reduce amount of CO2 will help make baby more comfortable, improve the gas exchanges, and improve the, reduce the work of breath. We have two main high flow nasal cannula. We have the high jet high flow nasal cannula, what's called Vapotherm. The Vapotherm claim that and I will explain to you after the slide, that the flow it comes is very, very, very fast. Velocity of the flow, because liter per minute is velocity, is very, very fast compared with regular high flow like the Fisher and Beckett and the other like ventilation high flow nasal cannula. So high flow nasal cannula, we have a Vapotherm, which is a stand machine. Hopefully I have the presentation, a picture I will show you later on. So here, this is the flow, regular flow comes like this. In the Vapotherm, they have a narrow before connected with the interface. Before connected in the face has the narrow, that's narrow creating jet pressure. And that's flush of the CO2 at the dead space. So this is the velocity in the regular flow bore, large bore versus narrow bore. So you can see in the large bore, regular goes like this, versus with the Vapotherm, because the velocity is very high, it's flush better. and better wash out of the CO2. Dynamic positive airway pressure, as we know, we said it's not intended, the high flow is not intended to provide positive pressure, but still it has, if you look at, it still delivers some pressure, and more you go on the flow, you might generate more pressure. The only difference that we don't know how much pressure we generate. And the level of pressure is depending on multiple factors, depending on the weight of the baby, the nostrils, depend on the sit flow rate you place it at, and the nurse occlusion. Or if the baby has the mouth open, same as the CPAP. If the baby is in the CPAP and the mouth is open, there's some leak. Baby, yes, he's receiving 6 or maybe 5 at the nose, but if the baby has an open mouth, the couple of the, or some of the pressure is going to drop. Do we need to block the mouth or close the mouth in order to maintain the pressure? And that's used to be practice. That's no longer recommendation because it's hazard risk. Okay, if the baby vomit or something, is not good to keep the tight or to shut the mouth or to close the mouth. So we know the baby is not going to receive a beep that you sit at least at the alveolar level, but it's good enough to maintain the alveoli open. Improve the warming and humidification of the respiratory gases without heated, humidified. So we said heated 37, humidified 100%, high flow 2 liter and above. The risk of the mucosal injury without humidification, there's increase in airway resistance, dryness, increase the secretions, obstructions. With the humidification, you improve the mucosal function, secretion clearance, improve the patient tolerance to the therapy due to reduce the mucosal injury. Okay, so that's the function of the heated, humidified, high flow nasal cannula. We have a different interface. The Vibotherm, they have their own interface. There is regular Fisher and Baguette, regular nasal cannula. Then the difference between a nasal cannula, and that's what we call it OptiFlow, also from the Fisher and Baguette, OptiFlow nasal cannula. The OptiFlow nasal cannula, sometimes when you use heated, humidified, the water condensed in the tube, and when close to the baby's nose, away from the heat system, it gets water condensation. And that's the water condensation sometimes dipping on the baby's nose and keep baby irritable, discomfort, because the water from time to time comes to the baby's nose. That's the OptiFlow. They make it as a circle, coily circle, comes all the way close to the baby nose, and that's maintained humidity, dry, humidified air all the way close to the baby's nose. So water condensation all the way down, not at the baby's entrance nose. So that's that, and you look at the baby here, happy baby, happy life. Okay, the way we measured depend on the color, and then you can, the RT, they measure the look at the color, and then they can figure out which interface, size of interface they use. Difference between nasal cannula and ram cannula. Ram cannula, look at this one, smaller bore. So this one smaller versus ram is bigger, thicker. And at the interface, the ram cannula is not like this. This one always fit for only for high flow. The ram cannula at the end has a universal connection. At the end of this one has a universal connection. The universal connection, you can connect it with any interface, respiratory support. You can connect with the CPAP, you can connect it with the Vibotherm, you can connect it with the with the ventilation, you can connect it with any. But when you use it in the high flow nasal cannula, again, the general rules, it has to be small ram. You cannot block the whole nose. There is no way for expiratory phase. So I can see it a lot, especially in my center, when I round. Because transition, they use from ventilation, they extubate the baby based on the ram, but they leave the ventilation. When you leave ventilation, you have to make sure that the baby can exhale the CO2. So you cannot block the entire nose. So you have to make sure at least you choose the smaller ram. Okay, so we talk about it. So where we are in the evidence, when we can use the high flow nasal cannula, at what gestational age? We can use the nasal cannula. Most of the strong evidence that we cannot use the ram cannula or There's high failure rate as a primary, as a failure extubation rate if you use it in the tiny baby less than 28 weeker. So that's the very clear, we have very clear evidence that if you use high flow nasal cannula less than 28 weeker, I will come to those evidence that always CPAP first. And that's based on the multi-center Cochrane trials, randomized control trials. Between 28 and 32 weeks, that's the gray zone. Some, they said you can use it, but you have to keep the rescue CPAP. Some centers, they said no, strongly no, you have to keep the CPAP until the 34-week corrected. You can, yes. Green zone, you can use it above the 34-weeker. Yes, you can use it clearly. Between the 28 to 32 or 34 weeks, that's the gray zone of using the high flow nasal cannula, depending on the where institution. Some institutions more advocate for high flow, they use it. Some centers, but use high flow. Some centers, they said big no, you have to keep baby on CPAP because there's no strong evidence yet. So let's talk about the three evidence what we have as a rule of the CPAP, rule of the high flow cannula as the primary mode. And we'll talk about number one, post-extubation support. Number two, we'll talk about evidence where we evidence the primary mode and alternative. So nasal high flow cannula as the post-extubation support, really in the Cochrane 2016 randomized controlled trials. The author, and that's when they conclude 6 randomized controlled trials. They look at preterm baby with respiratory distress received nasal cannula or high flow nasal cannula at 2 to 8 liters versus CPAP 2 to 8. They found no statistical significance in the rate of the treatment failure, no statistically significant difference in the rate of reintubation, no difference in the adverse outcome, significant reduction in the nasal trauma. So the only difference is here they've reported as a nasal trauma, but they conclude, these authors, that can be used as alternative. However, it suggests to have a rescue CPAP. Use it if therapy failed. Another studies look at from January 2013 to 2018, PubMed meta-analysis, 15 concluded. They also reported as high flow nasal cannula is not inferior to the CPAP when you use it for post-extubation for those baby 32 weeker or greater or in between. So, but no one talk about below 28 week gestation. But in American Academy of Pediatrics, there's a randomized controlled trials, high flow nasal cannula in preterm after extubation, and they enrolled all baby 6 tertiary NICU centers, infant less than 34 weeks. They compared for post-extubation between CPAP and high flow nasal cannula. They found high flow nasal cannula reveals significantly higher rate of treatment failure than nasal CPAP or NIPPV in preterm baby, and that's published in 2020. What does I'm trying to say here? Still, there's wide variation of the data result, depending on how much you start on the flow, how comfortable you are with the high flow nasal cannula in those gray zone age group. As a primary mode, 10 randomized controlled trials, 1,830 compared CPAP with the high flow, high risk of the therapy failure compared with the CPAP as a primary, but with the high flow, it's better, it's less likely to develop nasal injury. And they conclude, compared with the nasal, high flow may associate with the lower rate of the, compared with the nasal high flow, CPAP may associate with the lower rate of the initial therapy failure. So CPAP is better than as a primary mode. Another studies, 13 studies, 2,540, they look at the nasal high flow cannula compared with the CPAP as a primary mode. Is the conclusion is the same. Still, the treatment failure rate is higher on the high flow nasal cannula compared with the CPAP group. Again, high flow less likely to develop a pneumothorax nasal trauma, but failure rate is higher. And here you can see, since we don't have a lot of time, more favored toward CPAP group, but statistically slightly not significant. Okay, so in summary, high flow nasal cannula, you can use it clearly evidence above the at least 32 and above. Between 28 and 32 weeks to 34 weeks, that's the gray zone, depending on your institution. If you use it, you can start, most of the centers suggest 4 to 6 liters per minute. Make sure you have a humidified system. If you use the wall, you can use the Fisher and Baguette. Just you need blender and humidifier. Otherwise, you have to have the ventilation or the Vapotherm. And that's the Vapotherm. And that's the CPAP through the ventilation, or there's free set deliver just non-invasive respiratory support. And that's from the wall, just comes from, you need the blender and you need the humidifier, and you can use it from the Fisher and Baguette. Okay, so now let's go to the next. So now we talk about high flow nasal cannula. We talk about CPAP. We talk about the CPAP beep or CPAP on the variable flow CPAP. Let's talk about the final talk on the bi-level pressure. Dr. Adnan, do we still have a time or?
يعني ممكن maybe 15 minutes if it's possible.
Okay, so we'll do it quick, and then maybe another time we can talk in more in depth on the bi-level or NIPPV. The bi-level, you have a asynchrony and you have a synchrony. So asynchrony, the either dual limb. When we said dual limb, that means you have inspiratory, expiratory limb. That's closed loop cycle, which is very common in ventilation. That's the asynchrony, NIPPV, regardless baby's breath. Biff, 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 biff. And you have a single limb or limb variable flow DUBAB can give bi-level, which is the bi-level of the beep. CPAP, bi-level CPAP, DUBAB. You can control high pressure and lower pressure, but using the variable flow set with the valve, flip-lock valve that we talk about it, and that's the asynchrony. When we talk about synchronized bi-level, we have the most synchronized we have nowadays is the NAVA. And NAVA, this is another talk, is the neutral adjusted ventilatory assistant using the esophageal probe, sensing the diaphragmatic contractile movement. And that's the only ventilation provided is Baguette ventilation. And we have a non-invasive synchronized. The ventilations, because this one invasive, required esophageal probe. Esophageal probe every 2 weeks, you have to replace it with another one. And that's the risk, an expensive machine, expensive probe is expensive. The companies try to find alternative way to make it more synchronized or synchronize it, but less invasive, and try to run to make it as much as they can. We used to have the capsule, mnemonic capsule, over the baby's liver and sensing the baby's the abdominal movement. The more abdomen moved, ventilations give the breath. The issue with mnemonic, and that's provided through the single limb variable flow. The issue with this one, when the baby, and that's most of the ventilation, most company they no longer provided the mnemonic or the grasp skin capsule, because of that. When the baby has a shallow breathing, you cannot sensing, or baby is breathing very, very fast, it's hard to catch the ventilation, hard to catch the baby's breath. So it has a lot of artifacts. And so that's why it's not really truly synchronized unless baby is comfortable breathing. And then with the single lumen variable flow, we have the DUBAB. You can sit on the DUBAB, something called synchronized DUBAB. What does it mean? You have an inspiratory limb. We said in the variable flow, you have only single lumen or single limb. But when when you connect the baby nose, expiratory limb, you connected with, it does not completely come to the ventilation, but you connected with the sensor, the same sensor we used on the intubation. You connect the expiratory limb, and that's sensing the expiratory flow. What does it mean? The machine gives inspiration, okay, and the baby go all the way, and the baby exhaled, the exhalation go to this sensor, and then when the baby stop breathing, interruption in the flow in the expiratory limb, in the sensor measure the expiratory, knowing that since the flows get interrupted, the ventilation give breath. That means there's followed by, when you stop breathing, when you breathe, followed by inspiration. So exhalation followed by inspiration. So when you exhale, at the end of exhalation, the sensor sensing followed by the inspiration. That's called the synchronized DUBAB. Because of the single limb and use the flip-flop valve, there is risk of the leak. The machine claimed that they have, or they in their machine, they mentioned that they can compensate up to the 30% of the leak. So they are, and that's the only company provided is the Fabian, the synchronized part. The others, they have a DUBAB, but they are not providing the synchronized. The Acatronic Fabian, that they have the synchronized portion, they connected with the expiratory limb. The dual limb, so that's the single limb. The dual limb, which is the ventilation, regular ventilations, we have the most commonly the SLE and the Fabian. They provide, Draeger, they don't have the synchronized yet. So they provide they measure the pressure inside the circuit. And where's the sensor? At the proximal tube, sensing the changing in the pressure. The issue if there is leak, the pressure changing, and that's not right and ineffective. So you have the either expiratory limb, that's the single human, capsule, or pressure. The pressure, you have a SLE and Fabian, they can synchronize. Okay. Medtronic, they have very newest generation software. The sensor inside the software, and they have they measure on non-invasive, they measure how much pressure maybe at the interface level. So that's they have a very sophisticated software. They can measure the sensing inside the machine itself. Okay, so non-invasive, it's the work not only as a generated increase the alveolar ventilation and minute volume. It's it has advantage over CPAP by increasing main airway pressure. How? By giving extra BIB. CPAP, the same beep on the CPAP, but it has extra, another higher pressure called BIB, peak inspiratory pressure, and that's increase your main airway pressure. And that's a really important key concept here. In addition, the NIPPV provide another important factor to reduce obstruction and central apnea by stimulating the pharyngeal dilated muscle or dilator muscle and reduce inspiratory resistance. In addition, pushing the soft palate against the tongue. Small baby, we know it's floppy. We know they have a risk of the obstructive and central apnea. So that's when you place baby on IPV, you might push and stimulate the pharyngeal dilated muscle and also push the soft palate against the tongue. This is a setting. I'm not going to go over that details. The synchronize it, improve the tidal volume, reduce the work of breath, and reduce the risk of with synchronicity. It's maybe more comfortable. You reduce the imposed work of breath and less likely develop air leak and gastric overdistension. So very quick, the differences between the DUBAB, the bi-level, and NIPPV, for those who doesn't know. The NIPPV, the number one, the PIP pressure is very high. So you can go, usually, the maximum set pressure is that 25. Okay, so it's high. Usually we set. Usually we'd like to keep it below 25. So we said, okay, 18 to 20, that's usually the set of pressure. Versus in the DUBAB, the high level, usually we said 3 to 4 above your beep level. So if you set the beep of 5, you go 3 to 4 above the beep of 5 beep. So you set 8 or 9. So that's number one. That's the first difference. Number two, look at the I time. So for those new for this mechanical ventilation, so that's the beep. That's the BIB, inspiratory pressure, and that's I time, and then expiratory, and this one cycle. And similar, another cycle. BIB, I time, expiratory limb cycle, okay? So second is that look at short inspiratory time. Although it's longer than intubation. So if you intubate the baby, usually 0.3, 0.35. If you in acute phase, if you extubate the baby, usually we start 0.45 to 0.5. So don't forget about this. So it has the I time is around 0.4 to 0.45. So less than 0.5. In the DUBAB, longer. You start with the 0.5 up to 1. So it has number one, pressure 3 to 4 above the beep. Number 2, longer. The third difference is the less rate. The rate on the NIPPV 40 to 60. You can go down and you can go higher, but usually that's average. The rate usually low, 10 to 30. Okay? Here you can go as low as 10, but usually we like to keep it, that's the range, and then you can wean. The rate in the by CPAP or by level CPAP, the same DUBAP, is that between 10 to 30. So it's very small rate. So that's why it's like, so 2 levels of the PI, like the they called do high or and beep, or P high and peep. That's the DUBAP. So it's the highest pressure on the DUBAP, 15. You cannot go above 15. Okay, hopefully clear the concept. Okay, we're not going to talk about this. Very quick. So let's review the evidence that's important, and then we can conclude here or come with a summary. So nasal CPAP versus NIPPV. Okay, Dr. Ayad, which one I have to use? Now we talk about CPAP, we clarify CPAP high flow, and we talk about the gray zone. What about CPAP versus NIPPV? Which one I have to use first? Is it CPAP better, NIPPV better? And that's the dilemma here. So 2016 meta-analysis, 10 randomized controlled trials conclude that NIPPV reduced need for mechanical ventilation and intubation, lower failure extubation rate, and that's the most important factor. The failure extubation rate is higher when you extubate the baby on the CPAP than in NIPPV. Reduction need for mechanical ventilation and intubation, lower risk for respiratory failure. So better to place baby on NIPPV, but there is no difference on the bronchopulmonary dysplasia or death. Long term, there's no difference, only in the short term. That's just 2016. 2021, they add 8 more publications to the previous 2016. Those 11 of 18 trials, 11 demonstrate ventilator generated difference between ventilator CPAP and NIPPV with variable pressure. 5 trials use a variable flow, 2 trials mixed. And let's go to the conclusion, because we don't have time. Resulted, again, there is 37% relative reduction risk in the respiratory failure when you place baby on NIPPV. The greatest when you synchronize it. So if you decided, if I ask myself, it's better to use synchronized NIPPV than regular asynchronized ventilation generated asynchronicity. The number need to treat, if you used synchronized NIPPV, you need to treat 7 in order to prevent 1 respiratory failure. And this finding is the same like 2016. So now 2021 is the same on the respiratory failure. What about post-extubation respiratory support? Again, they demonstrate that in 15 trials, they enrolled 2,000, the same. So this is all 5 trials after the Cochrane 2016. 1,013 infant add on the previous meta-analysis. 12 of them ventilator-generated NIPPV, 2 of them flow variable, 1 mixed, and concludes that the first one we said 37 relative reduction risk, 22% in post-extubation relative reduction risk of the respiratory failure within the first week post-extubation compared with the CPAP. So it's always in tiny baby, better to use NIPPV, better to use as a first mode, better to use the NIPPV post-extubation. Extubation of 12 infant, you will prevent, so number need to treat every 12, 1 you prevent it. Again, this benefit was greatest if you are using synchronized over non-synchronized. What about bronchopulmonary dysplasia? Bronchopulmonary dysplasia, 14 out of 18 evaluated NIPPV versus CPAP and they look at the chronic lung disease, no significant difference. But in the latest 2021 Cochrane, they conclude when they did sub-analyzing their data, they found no, there is difference. If you're using synchronized, there's 28% relative reduction risk of bronchopulmonary dysplasia when you use the NIPPV, synchronized NIPPV. So if you look at asynchronized CPAP and chronic, there's no difference. But when sub-analyzing the data they look just on the synchronized group, they found the relative risk reduction is at 28%. What about mortality? There is no difference, as you can see in the first plot. Duration of hospitalization. 8 trials reported duration of hospitalization. NIPPV may reduce the duration of hospitalization, but those is a low certainty of evidence. Okay, so this is not another time. So in summary, the evidence always favored of using non-respiratory and non-invasive respiratory support as a primary line of treatment, and we keep emphasize the importance of non-invasive. It's clear evidence that in Cochrane 16, in adding to the 2021, NIPPV superior to the CPAP as a primary and post-extubation respiratory failure for prevention of respiratory failure and post-extubation respiratory support. The result show no reduction in the mortality overall within the subgroup, irrespective whether primary or post-extubation NIPPV support delivered. Not all the mode of NIPPV is the same as we classify for you guys and make it easy for you guys. And that's this classification, you're not going to find it anywhere. That's I created based on my experience. And when I work with multiple companies as a speaker, I start building my own differences. Any advances? So here, this is the most of the people highlighted. They said, hey, wait a second. You compared CPAP with NIPPV based on the P pressure. I cannot compare, it's not apple to apple. So you compared CPAP of 6 versus NIPPV, beep of 6, but you add the NIPPV. If you want to compare the machine to machine, you should use the same mean airway pressure. If you up on the beep and you are using keep the same mean airway pressure, you might get the similar result. And what that is to conclude here. Any advantage of the non-synchronized NIPPV may raise, I'm talking about in non-synchronized here, may raise from the higher mean airway pressure rather than from the intermittent pressure peak themselves. But that's not always right, especially in the tiny baby, because we said the mechanism, just the rate itself, the pressure, you push the blade for those baby who just born, tiny baby, the NIPPV might help the obstructive apnea and prevent the baby from help make baby awake. Synchronized and prevent apnea. Synchronization of the positive pressure ventil peak with the infant on-breath effort result is more effective and better tidal volume delivery. Nasal heated high flow nasal cannula, it's increasing the evidence used, but most of the increased use still within the gray zone. And we don't have strong to recommend one against the other, as we show in our data review. But we have enough evidence clear that you cannot use heated high flow nasal cannula for those less than 28 weeker, as a failure rate is higher and post-extubation rate is higher. And by now, we conclude and we are going for the question and answer. Thank you very much. That's my cell phone, my email. If you guys have any questions, feel free to ask. I'm happy to answer now and even later.
شكرا جزيلا دكتور أيمن. حياكم الله. شكرا. I'll stop the recording.
Sure.
المحاضرة يعني short مشان ما يكون يعني it's difficult to follow later on.